Hi, I'm Dr. Brian Kaufman, a retired family doctor and the Chief Medical Officer, co-founder, and Executive Vice President of the nonprofit CLL Society. And I'm going to talk to you about some important research, a study called SAVE, S-A-V-E, which stands for Safe Accelerated Venetoclax Escalation. The initial results of a study of an accelerated dose ramp-up of venetoclax in chronic lymphocytic leukemia, or CLL. This research was presented by Jennifer Leigh Crombie and several colleagues from Dana-Farber in Boston, who presented their results at the American Society of Clinical Oncology, or ASCO's, large annual meeting held in Chicago in 2023. Let me jump to the bottom line first. An accelerated 5-day venetoclax in hospital ramp-up can be safely done for most chronic lymphocytic leukemia, or CLL, patients with an acceptably low risk of tumor lysis syndrome. I'm going to provide the details that are related to that. So let's start with some background. Venetoclax is an extremely effective therapy for CLL, but its use in the community outside of academic centers has been slowed by the cumbersomeness and the difficulty of the 5-week ramp-up recommended to lower the risk of tumor lysis, or TLS, tumor lysis syndrome, or TLS, and the need for very careful and prescribed times of blood monitoring with each dose increase. Moreover, for a few, not many, but a few patients whose CLL is rapidly taking off, they may not have the luxury of waiting around for 5 weeks until you get to a therapeutic dose. So for many reasons, a safe, shorter ramp-up would be welcome. As a reminder, TLS, or tumor lysis syndrome, is best thought of as too much of a good thing. This is where large numbers of cancer cells are rapidly killed, and what happens is they release the contents inside the cells into the bloodstream. These intercellular contents include potassium, phosphates, and uric acid. And there can be so much of them that the body, specifically the kidneys, can't handle them safely. TLS can be, and tragically was, fatal early in the development of venetoclax, when it was not recognized just how quickly and powerfully venetoclax killed CLL cells. It slowed the development, and all trials were stopped when this was recognized until we could find a safe way to deal with it. The 5-week ramp-up now in place was a response to that safety concern raised by those early deaths from tumor lysis syndrome. So what were the methods and who were their participants? This is still an ongoing trial. It's a phase 1b trial, and it's for both treatment-naive, or frontline, and relapsed refractory CLL. To qualify, you need a diagnosis of CLL, and it needs to require treatment, and your kidney function has to be adequate. The primary endpoint was looking for what patients this would be safe in, what was the highest risk of tumor lysis that could be tolerated, who could tolerate this accelerated venetoclax ramp-up. Risk of tumor lysis varies from patient to patient, and it's primarily determined by the amount of CLL, or tumor burden, in the body, and the adequacy of the kidney functions to get rid of those intercellular components that spill out when the cancer is killed. The patients were treated inpatient with a 5-day venetoclax ramp-up. It went from 20 to 50 to 100 to 200 to 400 milligrams. That was the ramp-up. Labs were drawn pre-dose and at 4, 8, 12, and 24 hours after each dose, so you get a sense of the intensity of the monitoring. Rituximab and obinutuzumab were also given as part of the standard of care. So what are the results so far? So at the time of the reporting at ASCO, only 20 patients had been treated, but we did learn a lot. 19 patients had received obinutuzumab with venetoclax, and 1 patient venetoclax monotherapy. All patients were able to complete an accelerated venetoclax ramp-up, that 5-day ramp-up that I just talked about, with no one developing clinical tumor lysis syndrome. In other words, no one having any symptoms. There was 1 patient who had a medium risk of tumor lysis syndrome based on the tumor burden and renal functions, who had lab results but no symptoms suggesting tumor lysis. In his case, it was increased phosphates in uric acid that peaked at 8.7. And that was after the first highest dose of venetoclax, 400 milligrams. It required treatment. The treatment was successful, and it prolonged the ramp up to 6 days. The median inpatient time was 6 days. The range was from 5, which would be the minimum, up to 8. There were the usual adverse events that you see with venetoclax. Almost half the patients, 45%, developed low neutrophil counts. Over a third had low platelets. 1 patient died 2 months into treatment due to a complication of a bowel obstruction that was deemed to be unrelated to the study treatment. As you'd expect, the overall response rate was high. At 3 months, 89% in the 19 patients that could be evaluated had responded, including 2 remissions. Among the 19 patients that could be looked at after 3 months, 74 and 42% respectively had undetectable MRD, UMRD, in the peripheral blood in the bone marrow. So what can we conclude from this? We already knew that venetoclax was an extremely effective and generally well-tolerated therapy in treatment-naive and relapsed refractory CLL. Now these early results suggest that an accelerated 5-day venetoclax ramp-up is feasible in CLL with a low risk of developing tumor lysis syndrome. Due to the frequent lab tests required, the pre-dose in 4, 8, 12, and 24 hours following each dose, this accelerated ramp-up really needs to be done in hospital. For patients who would be better served by more quickly getting to a therapeutic dose, or who are bothered by the inconvenience and logistics of a slow ramp-up, there is reason to hope that this accelerated inpatient approach will be a safe option and will offer an option for patients who are far away from academic centers who could benefit from treatment with venetoclax. If you want to read more about this study and get deeper into the details, we have a link on the website. Thanks very much for your attention. Stay strong. We are all in this together.